Welcome, Texas Optometrists to Professional Responsibility 2018. My name is Kyle Sandberg. I'm an assistant clinical professor here at the Rosenberg School of Optometry. This is the one-hour course in professional responsibility or ethics that's mandated by the Texas Optometry Board each year in order to renew your license. So this course satisfies that requirement. It is accompanied by a quiz, should be on the same webpage with instructions. So take that quiz after you complete this course or listen to this video, and then send it into the RSO CE office. We'll grade it and then send it off to the board, and you'll receive credit. So the topics that are covered here are mandated by the board. They send out a list and say, hey, we got to talk about these different things each year. So a lot of different rules and changes and things like that we'll cover here, and some reminders as well. Keep you out of trouble here in the future. I realize it can be a little bit dry, so I've added some background music provided by yours truly. So hopefully that makes it a little bit more entertaining. And with that, we'll go ahead and get started. I like to start each one of these presentations by just reminding you that the TOB maintains a website here at tob.state.tx.us. This is mostly for new optometrists to the state, but you'll recognize that this website has changed in the past year compared to previous years. They still have a lot of the same links, but the design looks a little bit different. Here we can see the CE link, and that's a great place to check your CE. Keep in mind, though, that the CE credits, once they're received by the board, are posted there, but also the board meets 4 times a year to approve CE courses, so sometimes there's a little bit of a delay in getting those up. We also have a link to the Peer Assistance Program. We'll talk about that more later on in the presentation. I'd also point out that Top Optometrists link up here. If you click on that link, there are several useful links there about laws and things like that, but the newsletter link is also contained on that page. And the newsletter is the primary way that the board communicates with licensees. So it's important that you read the newsletter each year. It typically comes out in August. It has a lot of updates on rules and changes. This course supplements the newsletter, but the assumption by the board is that every optometrist reads the newsletter. So if you haven't read it, please take the time to do so. It's only a handful of pages, and there's a lot of really good information in there. I think that's going to take you to this page, and then you're going to click that check website for CE hours right there on the top left. That will take you to this page where you can input your license number, and of course it's reminding you there about the professional responsibility course. We can see that the CE requirements for active licensees contain 16 hours of CE each year. 6 or more of those have to be in the treatment of ocular disease, so they call those DT hours, diagnosis and treatment of ocular disease. 8 or more hours must be live. You can only take 4 hours at a grand rounds course like we have here at RSO on Friday mornings, and 1 hour is this professional responsibility course. CE credit, and so that'll take you here, and you can see that it outlines regular hours, diagnosis and treatment hours, as well as ethics hours. So make sure you've got 16 total, and we're hitting all those things. So let's jump into sort of the meat of the presentation here and talk about some changes to Texas Optometry in 2018. So the first thing that happened last year, early in 2017, was the passage of Senate Bill 314, and that allowed Texas Optometry to remain independent for 12 more years. So if you're unaware, every 12 years the Sunset Act comes up, and that looks at all health professions. This year, the recommendation of the Sunset Commission, or I should say in 2017, the recommendation of the Sunset Commission was to roll the Texas Optometry Board under TDLR and get rid of the Optometry Board altogether. And so we would have been governed essentially by a board that regulates electricians and elevator repairmen and things like that. And so with the help of ODs throughout the state and the TOA, we were able to successfully defend the existence of the Texas Optometry Board. So many thanks to the doctors that contributed to that. So here's the place I've got to mention what the TOA is doing, both in 2018 and 2019. As many of you know, 2019 will be another legislative year, and so as we go into session, the plan here from the TOA is to push for scope. We're calling it the modernization of eye care, but it's really going to expand what Texas optometrists are allowed to do, and it's our hope that we bring Texas to the top 10 from where we are right now, ranked about 47th in our ability to practice optometry. The thing that you can do right now is, number one, join the TOA. If you're not already a member, please consider joining. It's important because it unites all Texas optometrists as one solid voice, and it allows us to speak to the legislator in Austin with a collective unity. You can reach out to your legislators starting now, start telling them the issues that are facing optometry, both from a scope standpoint and insurance panels and things where optometrists are treated unfairly. But especially in 19, when we need one voice. For example, if we have a House bill or a Senate bill that's coming onto the floor or that's being heard in committee and we need support for it from across the state, if those offices are flooded with emails and phone calls, it's hard for the legislators to ignore that many voices. And so being part of that and knowing when and how to reach out is going to be imperative as we move the profession of optometry forward here in 2019. So Senate Bill 314 changed some other things about optometry. One of the things that changed is the license renewal fee, and those are going to increase coming up this year. We're going to add $5.29 to the optometric glaucoma specialist renewal fee. The purpose of that is because Senate Bill 314 is trying to address opioid abuse. New legislation is adding duties for the Texas State Board of Pharmacy. They operate the prescription monitoring program. We'll talk about the prescription monitoring program here in just a minute. But because there's a cost associated with that, the increase in the fee for optometric glaucoma specialists is going to be $5.29 annually. The other thing they're going to add is $2.36, and that is because the board is now required to access the National Practitioners Data Bank at each license renewal. And then what this does is it allows the board to see if there's been any disciplinary action or any license revocations in other states across the country. This actually is cheaper than the licensee doing it themselves. So one of the thoughts was, should we allow the licensee to access this National Practitioners Data Bank themselves? There's actually a $2 savings if the board just adds it to the license fee. The next thing is the application process is going to be online, so that cuts away some paperwork. Another nice thing, anonymous complaints can no longer be accepted by the board. So if a complaint comes in against you, previously the patient or consumer was allowed to leave their name off of those complaints. Now that is not going to happen anymore. So hopefully this cuts back on some frivolous complaints against optometrists. The other thing they changed was modernizing some language and the ability of the board to discipline for mental addiction or impairment. And I'll tell you in the next slide what that sounded like and what we've changed it to. So here's what that language looked like. Previously, the Optometry Act had authorized disciplinary action by the board if the optometrist is a habitual drunkard, is addicted to the use of morphine, cocaine, or other drugs having similar effect, or has become insane. So kind of specific there with substance abuse. The new language sort of covers a broad range of different things. So they changed it to has developed an incapacity that prevents or could prevent the applicant or license holder from practicing optometry or therapeutic optometry with reasonable skill, competence, and safety to the public. So again, just sort of modernizing what was in the act to reflect more modern day practices. One of the other things that is added because of Senate Bill 314 is the requirement to be fingerprinted in Texas. So this is actually going to only affect you if you were licensed prior to 2008, because since 2008 the board has been fingerprinting licensees. So if you were licensed more than 10 years ago, this is going to affect you. Every year, about a fifth of the doctors in Texas are going to be asked to submit fingerprints, and so therefore at the end of a 5-year period, 100% will be fingerprinted. This is also obviously a requirement for new licensees, not just docs that are already there. If fingerprints are required to renew, what's going to happen is the board is going to send you a letter in October telling you that you've been selected as one of that 20% for the year, and you need to get your fingerprinting done. There is a fee for electronic fingerprinting. This is only a one-time requirement, so once you have it done, you don't have to worry about it in the future. So as I mentioned, the board is now authorized to and actually required to check the National Practitioners Data Bank. What they're going to be looking for is disciplinary action taken by another state. If they find that disciplinary action has been taken against you in another state and you have not reported it on your application, that would be considered a fraudulent application, and then they are required, or authorized rather, to take additional disciplinary action if they find those things. I mentioned the increase in the fee for optometric glaucoma specialists as it relates to the prescription monitoring program. So what's happening here is the State Board of Pharmacy is the operator of this program. They are asking or requiring, this is one of the things that Senate Bill 314 does, that if any practitioner in the state is prescribing opioids, benzodiazepines, barbiturates, etc., that any controlled substance, that you first access the prescription monitoring program. And the goal here is to limit doctor shopping and see if a patient has been trying to get prescription medications from multiple different providers. And so that can be flagged in the system here. Optometric glaucoma specialists can access the database effective right now, but required beginning September 1st of next year. So if you'd like to sign up, you can do so. I'll give you information about that on the next slide. But you cannot register, you don't have to register at all if you don't have a DEA number. That's part of the registration process. So if you don't have a DEA number, you're not prescribing controlled substances, therefore you're not required to register. If you are required to register, the website is there, texas.pmpaware.net/login. There is more info about the program at the pharmacy board's website, so pharmacy.texas.gov/PMP. So again, Texas pharmacists are required to submit all prescriptions for controlled substances into this database, and then the Texas Pharmacy Board is going to monitor and maintain that database. As I mentioned, the goal here is to limit that doctor shopping. The requirement, again, does not start until September 1st next year. So I want to jump into a case study. Here the board has required us to talk about, this is one of the topics they had on the list for this year, and so I think it's well illustrated by this case study. So Jack Dawson, OD, is invited to attend the CE event at his town's local steakhouse. The event is being put on by the new cataract surgeon in town, Margaret Brown, MD. She's interested in educating the OD community about a new presbyopia-correcting IOL that her practice has just begun using. The dinner, wine, and educational course are all included at no cost to Dr. Dawson. Dr. Brown suggests at the end of dinner that, quote, "Our practice would appreciate the opportunity to create a relationship with all of your Medicare patients in need of cataract surgery." So do we see any problems here? And if so, what are they? So the issue in this scenario is that we may be in violation here of the anti-kickback statute. So the anti-kickback statute prohibits giving, receiving, or soliciting any items of value, either directly or indirectly, for the purposes of inducing or rewarding items or services that are reimbursable by the federal government. So here, because the CE is provided for free, dinner is provided for free, there's wine provided for free, that could be viewed as remuneration for referrals of Medicare patients to this practice. And the hard part here is that the doctor specifically requests the referrals of Medicare patients. It doesn't mean that you can't go to CEs that are provided by your local cataract surgeon. It just means that if the cataract surgeon is soliciting direct referral of only government-insured patients, that you might be in sort of a gray area there. Violators are subject to monetary penalties, imprisonment, or both. Violations can cost up to $50,000 plus 3 times the amount of the remuneration that has to be paid back. Additionally, the provider is excluded from federal health care programs, so this can be a real death sentence depending on your patient population, but if you are no longer allowed to be reimbursed for Medicare and Medicaid patients, it may be an issue for your practice. The thing that's also important to note here is that under the anti-kickback statute, both parties are held liable. So it's not just the person soliciting the referral, it's the person providing the referral. So I've got a little copay quiz for you here as it relates to Medicare and Medicaid patients. Most of this information comes from the Office of the Inspector General. I'll give you the link to this information here. You can see some of the link here at the bottom of the page, but I'll give you the actual roadmap for new physicians website here at the end. Tons of good information there. So let's ask this question: can you waive a copay for an individual Medicare patient even though you routinely charge all of your Medicare patients their copays? And so, what's your answer? You can say it out loud if you want. I can hear you. The answer is actually yes here. If you determine that the individual patient cannot afford to pay, or if reasonable collection efforts fail. You work in an underserved community. Can you advertise your policy of waiving copays for special financial circumstances? So we just said that you could waive your copays for special financial circumstances, but are you allowed to advertise them? The answer here is no. You may never advertise that your practice has a policy of forgiving or waiving copayments. Alright, since many of the individuals in your community are uninsured, are you allowed to treat them for a discounted rate or offer them free services? And the answer here, of course, is yes. Federal law does not place restrictions on offering free or discounted services to the uninsured. One more. You decide that you'd like to offer free care to all of your patients, including Medicare and Medicaid recipients, by waiving their copays. You have to keep the doors open, so you send the claims to Medicare and Medicaid for the payment. Is this allowed? The answer here is no. So federal law doesn't prohibit you from offering free care to Medicare and Medicaid patients, but if you bill the government for services and don't collect the copays, technically you're not providing free care. And so in that case, that will be illegal. If you're going to bill the government, you have to bill the patient as well. So we also need to talk about the False Claims Act, and sometimes Anti-Kickback Statute, False Claims Act, Stark Law get kind of bundled into one. But really what the False Claims Act says is that you can't submit false or fraudulent claims to the government. The thing that applies here is that even if you don't know that you're doing it, you're still held liable. So it's important that you read up and follow up on laws and changes to those laws. I'll give you some examples here of what would be considered fraud in just a slide or two. Note that there are incentives to report fraud, and so a lot of times when fraud is reported, it's by these whistleblowers. They turn out to be ex-business partners, hospital or office staff, competitors, or even patients. And the reason is because whistleblowers can receive up to 30% of any False Claims Act recovery. So whatever the government gets back, 30% of that can go towards the actual person who reported it. Some examples of fraud, and there's 3 different categories that you can fall into: provider, patient, or insurer, and you can see some of those examples here. So obviously from a provider standpoint, that's where we want to be most concentrated here. So if you're billing for services that weren't performed, obviously that would be considered fraud. If you bill more than once for a service that was only performed once, falsify a diagnosis, billing for more costly services than the ones that were performed, accepting kickbacks for patient referrals. So here you're violating both anti-kickback, but also because of that you're going to fall into this fraud category and violate the False Claims Act. Billing for non-covered services when a non-covered service, billing for a covered service when a non-covered service was provided, ordering excessive or inappropriate tests, and prescribing things that are not necessary. This is that roadmap for new physicians. It is a document that's available online. It's about 30 pages. It goes through a lot of the stuff that I'm talking about here. I would recommend, even if you're not a new physician, that you take a quick read through it, because it has a lot of valuable information. And again, we mentioned already that you can't just claim ignorance. You can't say that you didn't know. It's your job as a health provider to know this information, and so making sure that you read through these types of things. This is a great pamphlet here because it really puts things in pretty simplified terms. So the board wants everybody to understand that it does not make any of the determinations of any of the things that we've just talked about. So False Claims Act, Anti-Kickback, Stark Law, exclusion, and civil monetary penalties law. All of those, again, are reviewed in that Roadmap for New Physicians pamphlet. So read up on those, but it's really not the role of the board to make any of those determinations. That's determined on a federal level. Approval of CE courses is based on the individual course meeting requirements set forth in the Optometry Act. If you want to look at what those are, it's Section 351.308 in the Optometry Act, but ultimately what happens is the board meets several times a year, 4 times to be exact, and determines which courses are approved. One of the things that the board asked we address this year in this course is illegal contact lens sales. So this is something that I know is affecting most of Texas optometrists in private practice or even outside that. Really, we want to talk about what they are, what the laws are, and what you can do to prevent illegal contact lens sales. The basis for a lot of the things that we'll talk about here as far as the legality of contact lens prescribing comes from the contact lens rule, which was passed in 2004. It really has 2 key requirements. The first is that prescribers provide patients with a copy of their contact lens prescriptions at the completion of the contact lens fitting. It's important to note that the contact lens fitting is finished when you say it's finished. It's not at the beginning or the first visit. There may be multiple follow-ups involved, and when you are actually ready to prescribe the contact lens and you're satisfied with the fit, that's the time that you're required to give the patient a copy of their prescription. The second part is that a contact lens seller cannot provide contact lenses to its customer unless the seller obtains a copy of the prescription or verifies it from the prescriber through the procedures that are set forth in the rule. And I'll talk about those specific procedures here in a second. The idea behind this is that the FTC is trying to enhance consumer choice and competition among contact lens sellers, which should theoretically benefit customers. The problem, of course, becomes when contact lens sellers don't abide by these rules and prescribe or provide contact lenses rather to their patients or customers without proper prescriptions. Contact lens verification is defined by the following. The seller is required to contact the prescriber by direct communication, which means either fax, email, or telephone, for a verification of a contact lens prescription. If the prescriber does not notify the seller within 8 business hours that the prescription is expired, inaccurate, or otherwise invalid, the seller is then authorized to treat the prescription as verified. It's important to know what 8 business hours are, and we've talked about this in previous courses, but 8 business hours in this rule are defined as 9 to 5, Monday through Friday. They exclude federal holidays. They should be in the prescriber's time zone. And if the seller determines that the prescriber has regular Saturday business hours, those hours would count as well. So whatever time that message is left or faxed or whatever it may be, the clock starts then. At 5 o'clock, the clock stops. The next business day, the clock starts again at 9 a.m. Once 8 hours have elapsed, then the seller is legally allowed to prescribe or ship those contact lenses in many cases. So the reporting of adverse events becomes an important role of the optometrist. Because these patients come into our office, whether it's a contact lens prescribed by you or something they got offline or a cosmetic lens that they got in the gas station down the street, when we see these adverse events, it's important that they be reported, because if they're not, the public perception of the safety of contact lenses continues. So abuse, overwear, and getting prescriptions or getting contact lenses without prescriptions continues by the public. So I wanted to share with you, in March of 2017, an article published in The Hill by Tim Devaney quoted the founder of Lens.com, stating, "Globally, there are many countries like Germany where contact lenses don't require prescriptions. They're sold over the counter. I don't see any Germans walking around with eye patches because they're going blind." So obviously, we know that that's not the case. We can see a myriad of infections or adverse events that happen from contact lens abuse and overwear here in this article, this Lens.com founder is trying to state the exact opposite. Same person also called optometry's warnings about the dangers of online contact lens sales a scare tactic that were employed by doctors to protect their bottom line. And you can see how the public might empathize with that. So it's important that we get these adverse events to the right sources so that they can be logged and we can show that proper contact lens prescription and contact lens use is a public health issue. So how do we help? How do we solve this problem? Well, submitting MedWatch reports of any adverse events is the first step. So if you see anything, any complications that are associated with contact lens abuse or getting prescriptions illegally or without prescriptions, they should be submitted to the FDA. They're at fda.gov/safety/MedWatch. The link, of course, is right there. The other thing we want to do is notify the Office of Compliance of any illegal contact lens sales. So contact lens sales without a prescription, or contact lens sales that you have denied or said that there's an expired prescription, and yet the patient somehow ends up with the contact lenses anyways. Another website at the FDA, just a different page on the FDA's website, is reporting problems for contact lens vendors that are selling without a prescription. The other thing you can do is go to the FTC. The FTC's website, to me, is a little bit more complicated as far as where we're trying to submit these things. So on the left side, you're going to see a drop-down menu. Make sure you click Other and then follow Health and Fitness. From there, you can follow the prompts to submit a contact lens complaint. So there's a page with contact lens and eyeglass complaints. Every year I like to do a section on routine mistakes. These are easily avoidable mistakes. They can cost you money because the board is looking out for them, and if you happen to be in violation of one of these, you can easily be fined by the board. They go over these every year in the newsletter, so again, I encourage you to read the newsletter, both this year and the previous ones as well. There's always a section on fines against optometrists or disciplinary actions taken against optometrists. So if you look through that quickly, you can get an idea of what other people are doing wrong and help yourself to avoid these mistakes. But let's go over a few right here. So here's a little quiz. Which of the following is an appropriate way for an optometrist to identify themselves in Texas? And we've got some examples here. Dr. Jonathan Snow, optometrist. Daenerys Targaryen, OD. Dr. Tyrion Lannister, OD. Gregor Clegane, Doctor of Optometry. Or Sansa Stark, optometric physician. Which of those is inappropriate? And so if you remember from previous lectures, or if you've read the newsletter, or if you've looked at the statute, the things that we want to avoid are the third and the fifth option here. Here are the examples, and this is right out of the newsletter, but this is also spelled out in the statute. It's in the occupations code. For an OD, an optometrist in Texas, the identifications listed here are the ones that are appropriate. So you can either use OD, you can use Doctor of Optometry, you can use Optometrist, or you can use Doctor as a prefix with Optometrist. And that's really the only time that you can use Doctor. A therapeutic optometrist can use any of the above, any of the ones that we just mentioned, or you can add therapeutic optometrist, or you can do Doctor and therapeutic optometrist. For an optometric glaucoma specialist, it's pretty similar, but you have to use it in conjunction with one of the designations that was mentioned on the previous slide. So, for example, you might say Mike Siever, OD, optometric glaucoma specialist, or Jesse Kostopoulos, therapeutic optometrist, optometric glaucoma specialist. So again, just throwing in that comma and then putting optometric glaucoma specialist afterwards. Where do you have to list these specific designations? Well, it's pretty much any time your name is in print or in advertising or any time it's shown throughout the office. So it might be on the door of your practice or any other sign that's out by the roadway or anything like that. Any of your business cards, prescription pads, phone book, or electronic listings, anytime you're listed on the website, it should refer to you as that stationery or billing invoices. Another caveat that comes up every year is the use of board certified. And so the reminder here from the board is that the optometry board does not actually certify any optometrists. All they do are license Texas optometrists. They also regulate the profession in the state, but there is no board certification that's conferred by the Texas Optometry Board. If you use that term by itself, board certified, a patient or a consumer might take that to mean that the Texas Optometry Board, is the one passing the certification. So if you are going to use the term board certified in print or advertising, you can do it, but you have to use the name of the organization that conferred that certification. So for example, Ziggy Chapman, OD, board certified American Board of Optometry. So if there's any sort of board certification, it just has to be followed by the organization that confers that certification. Just like board certified, specialist is another term that people get into hot water by using it incorrectly. So the term specialist is not allowed to be used by an optometrist unless you're saying the specific organization that confers that specialty. So you can't just say glaucoma specialist. Optometric glaucoma specialist is allowed because it's a separate category that's recognized in Texas for optometrists. An example of something that would be allowed would be William Byers, OD, contact lens specialist, and then saying certified by the North American Contact Lens Foundation. The exception here is that if you specialize in a certain type of treatment, you're not calling yourself a specialist, you're just saying that you specialize. That actually is allowed. So you might say, for example, Nancy Wheeler, doctor of optometry, specializes in the diagnosis and treatment of binocular vision disorders in the pediatric population or in pediatric patients. That would be acceptable because you're not calling yourself a specialist in that case, but telling what you specialized in. And so that might be appropriate to put in a pamphlet or on your website or in any other sort of advertisement. Alright, so I'd like to look at a case study here that I think illustrates some important points. So let's take the case of Ginger Grant, OD, and she's been in her private practice for about 8 years, and she's decided that she'd like to hire a part-time OD employee to help her on Wednesdays and Saturdays. So working a total of about 12 hours a week. On February 1st, 2017, she hires Dr. Jonas Grumby, optometrist. By the time Dr. Grant is enjoying a margarita for Cinco de Mayo, which of the following is she required to have completed regarding Dr. Grumby's employment? A. Credentialed Dr. Grumby on all insurance panels. B. Added Dr. Grumby's name to the practice door. C. Verified that Dr. Grumby has a license to practice in Texas. Or D. Provided training regarding HIPAA compliance to Dr. Grumby. So keeping in mind that Dr. Grumby is only working part-time here, about 12 hours a week. And they've kept up that relationship for about the 90 days or so that he has been employed with Dr. Grant. So the answer is all of those except for the first, which is credentialing Dr. Grumby on all insurance panels. Of course, that may be a good idea from a practice management standpoint, but it's not required. Dr. Grumby is on any insurance panels. You can see uninsured patients or specific panels that only he's credentialed on. So let's talk about these one by one. So the law says, and this is section 351.362, that for fill-in or part-time doctors, that the doctor's name has to be displayed in a publicly visible place, and specifically on the door. It has to be displayed where a patient would see it as they're entering the practice. That's only the case if they're practicing optometry for at least 2 consecutive months, and that's what they define as a regular basis. So for example, if a doctor practices at a location just on Mondays for a 3-month period, that would actually satisfy that 2 consecutive months. So it just has to be, it doesn't matter how many days a week, it's really just asking if they're there on a regular basis over a 2-month period. And if the answer is yes, then that doctor's name has to be on the door. What about for license verification? So section 351.501 says the board may refuse to issue a license to an applicant, impose a fine, or reprimand a license holder if the board determines that, and then jump down to section 501.5, if they determine that the license holder has directly or indirectly employed, hired, procured, or induced a person to practice optometry or therapeutic optometry in this state without a license. So how do you do that? And really, this goes back to making sure that whoever you're hiring is licensed in Texas. And this had been a problem in the past. Actually, you can read one of these stories in the newsletter where an optometrist was continually soliciting work on online forums, but actually didn't have a license to practice. And in that case, both that optometrist and the hiring optometrist would be held liable and subject to a fine. So very easy to check license verification. If you just go to the board's website, tob.texas.gov, and look at this license search site. So I've included the link here for you. This is exactly what the site looks like. Just type in the license number, and in fact, that's really all you need. If you want to get more specific in those other fields there, you're absolutely able to do that. A note about training your employees. This is from the Health and Occupations Code, section 181.101. It's called Training Required, and specifically as it relates to HIPAA compliance. So it says each covered entity shall provide training to employees of the covered entity regarding the state and federal law concerning protected health information as necessary and appropriate for the employees to carry out the employee's duty for the covered entity. It also says that this has to be done within the first 90 days, and that you should require your employee who has received the training to sign something that says that they verify that they've received the training and they understand the training. It doesn't mention anything about whether that employee is part-time or full-time. So to be on the safe side, it's recommended that you train all of your employees to meet this requirement. We've got a little section here on EMR pointers. This comes from the board. It also has some things listed in the newsletter. I've looked into it a little bit further for you guys, but especially as it relates to court cases in the past, really easy to avoid mistakes if you just take a little bit of time and make sure that some of these things are in place in your EMR. Of course, as the health system moves to electronic records, there is going to be a little bit of a learning curve, but making sure that you're up to date on these things is definitely going to be helpful and can help you to avoid some legal backlash. Hopefully that doesn't come your way, but if it does, make sure that you're prepared. So the board can request records from your office for a couple different reasons. The two main ones here are while investigating a complaint or just during a routine office inspection that can kind of happen randomly. If they request records from your office and you have some general sort of errors across the board in your records, even if it's not an intentional error, if it's something that's just kind of pre-populated, it can cast doubt on the validity of all the records that you have. And I'll show you here in a few minutes some examples of court cases where because of those little errors in the records, the court has actually ruled in favor of the plaintiff when somebody is coming after a doctor claiming negligence or something like that. And the court says, hey, we can't believe these records because of these consistent little errors. It makes us question whether or not any of the information in the chart is actually accurate. So one of the very common ones is using these pre-populated or pull-down menus that are just automatically put into the chart even after the chart is signed. And it doesn't mean that patients can't have the same findings. It just means if that finding does not apply to a specific patient, it's a red flag that you're just pre-populating many different fields. So I'll give you an example. I've seen charts that say, for example, in a 9-year-old patient, the patient was warned against driving. So that might be something that you put in for your adult population, or you say there's some sort of conversation you have about driving or using sunglasses or something well dilated. but it doesn't make sense in a pediatric chart. And so if it appears in all of your pediatric patients, it's very obvious that that's just one piece of information that's going to jump into the chart without anybody paying attention. And so that brings into question, how many other places in the chart is that happening, and can we really trust this chart? Another very common error, the same information is repeated verbatim across records of different exams for the same patient. So using the same date or using the same presenting symptoms across different exams. So something that should be resolving with treatment, and maybe you've indicated in your assessment and plan that it's resolving, but the patient complaint appears the same at every single visit. In one case, we saw a case of a plaintiff that contended inappropriate use of an antibiotic, and that caused him to require dialysis. The same date appeared on each of the 3,000 pages in the record. This is out of an article, but it said that the judge, quote, said, "You have a problem. Neither you nor your client can make sense of this." The case eventually settled for $10 million. So that's a case where just some negligence and over and over seeing the same date on 3,000 different pages called into question the validity of the entire chart. Another really common error, and this is straight from the board, is that if you have some sort of paper testing that normally would have been attached to your records, that paper testing doesn't end up making it into the electronic record. And so you need to have a system in place to make sure that happens. Great examples of that would be like a printout from a visual field that should be scanned into the record, or a autorefractor that's finished that day. And the autorefractor tape may just be stapled to the paper in the practice, but then it's not actually put into the electronic record. If you do a test, or part of a test, or part of an exam, and you bill for it, it needs to be shown that you did it in the electronic record. So when they brought this up to doctors before, the doctor's response has been, "Hey, we just started using EMR. I didn't realize that this wasn't making it into the chart." And the board's response to that is that you can't claim negligence here. You need to make sure that you're doing these things ahead of time as you transition to EMR. Another very common problem is your inability to print out a complete record which has the same information as the EMR. So this is usually just a software issue. Maybe you're seeing it on screen, or maybe it has multiple pages or different menus or items that you need to click to include the complete record. I personally just had this problem the other day. I was trying to get records for a patient, and I needed visual fields and OCTs, and they claimed over and over and over that they were sending me the complete record. It wasn't happening. I wasn't getting it, and it was partially, the fact that the technician on the other end, or the front desk worker didn't really understand exactly what we were asking for. But when she was clicking print on the complete record, everything wasn't coming out because there was a separate menu where she needed to print out visual fields. I'm making this assumption, but there was somewhere else that she needed to print out visual fields and OCT records. So make sure that when you're asked for a complete record, that you're able to print that out, and and your staff is trained on how to print that out. So do some practice things like that. Imagine that you are auditing a chart and try to make sure that you can get all of the information from a single patient pretty easily and seamlessly, and that your staff knows how to do the same. If you are releasing prescriptions, you need to either have a copy of that in there, or you need to have information that says that you released maybe the manifest prescription, or refer back to it in the chart. This helps, as we were talking about earlier with contact lenses. We want to be able to show, as the FTC requires in the contact lens rule, that we are giving patients prescriptions at the final contact lens fit. But for glasses and contacts or medications across the board, if you're prescribing things, it's a helpful record, and a required record actually, that you are showing that when you prescribed it, you gave it to the patient that day. So a great example of that, of course, would be a scanned handwritten prescription. But if you're e-prescribing or something like that, at least you have some of the record there. But it should have some notes within the chart that you release prescriptions. This last one is one where you need to kind of sit down with your staff, your office managers, and figure out the way that you're doing these types of things. So in this case, the one that they're concerned about is having information that's given to you by the patient and getting it into the chart. Knowing where that information is in the chart and making sure it becomes part of the record. So if a patient gives you a driver's license, or if a patient gives you a medication list, or if a patient gives you previous records from another doctor, how do those get into the chart? How does that become part of the record? And making sure that everybody's on the same page, those are going to the same place. So if you are audited and you're asked to print out that chart, that it makes it in the final printout and becomes part of the record that you would give to somebody else. I want to switch gears and talk a little bit about ADA compliance, or the Americans with Disabilities Act, and how your office falls into a category where ADA compliance is required. Doctors' offices are considered sort of public spaces where ADA compliance is required, and so you need to make sure that your office is up to date. We've talked about some of these in the past, and again, the newsletter has reviewed some of these things, but I want to bring up some information here specifically about your website. It's very, very uncommon now that your practice would not have a website or some sort of online presence. And because you're a doctor's office, how do those ADA compliance rules apply to your website? So I want to give you an example here of a patient that recently had threatened to sue an OD, and actually several other doctors that were sort of on her healthcare team, because the website that they maintained was not ADA compliant. As I said, the offices of optometrists are covered under the Americans with Disabilities Act, and that does include your website. So how do we make it ADA compliant? If you're anything like me and you don't practice in low vision, you might not know exactly how the visually impaired access websites. I thought I'd just show you an example here real quick. This is a video I pulled off YouTube. There's two main ways that they can access the text on a website, or what's visually happening on the screen. One of which is obviously with just a text-to-speech software that's going to read what's on the screen, so the patient is able to listen to what is actually on the screen or on the web page. The other are these Braille readers. So the Braille reader translates what's on the screen text into Braille. And so that looks like this. Again, this is just a video I pulled from YouTube, so it's not the highest quality, but I think it gives you the point here. The text is obviously changing as whatever is on the screen is being kind of highlighted or read through. So because of that, it's important that some of the things that we're going to talk about here are compliant on your website. And I think if there's any profession that should be sensitive to this, it's probably optometry. So making these changes to your website should be relatively easy and also important for your patients. Direct from the ADA here are 4 common problems in web design relating to ADA compliance. You can see I've got that source website down there at the bottom, so all this comes directly from their website, and I'd encourage you to look over it because it can help you. There's actually many tools, links to other websites that can help you check your own website's compliance with the ADA. But number 1 is images without text equivalents. So if you include an image on your website, obviously a visually impaired or blind person is going to be unable to see that, and so they suggest you put in lines of HTML code to allow text readers to describe the image. They should provide a text equivalent of the image. So it should be a full description of what's in that image. If you have documents posted on your website, and many of us do, right, for patient forms and things like that you want them to fill out before they get into the office, make sure that it's posted in an accessible format. So many times PDFs are not accessible to screen readers because they use many images. So make sure that you provide your documents in HTML or rich text format, RTF format, in addition to the PDF. So that's a pretty easy fix. If your web page has locked colors and font sizes, that can also be a barrier to somebody who's visually impaired. So make sure that your website allows the user to change colors and font sizes. And that's probably just a setting that you can talk to your web designer about. Pretty easy to change. If you have videos and other multimedia tools, those need to have accessible features as well. So make sure you're providing audio descriptions in videos and subtitle text for videos if you have those on your website. I want to throw in a quick note about CE here. It's important that you get your CE in on time. If your CE is not valid or validated and you've applied for the new license and you don't have your new license by January 1st, you can be fined for practicing optometry without a license in Texas. So please make sure you get your CE in on time. CE certificates can be mailed directly to the board, faxed at that number, or emailed, and all that can be found on the website. I'll share some more information with you at the last slide here. Make sure that the CE certificates are sent in. So the courses that you attend maybe will provide attendance certificates to the board, but not all of them will. So make sure that you're sending your own certificates, or at least verify that they're being sent in, and then check on the website quarterly to make sure that you've received credit for those courses. Submit the certificates as soon as you receive them. Don't wait till the end of the year. That speeds up the process quite a bit. Again, the board meets in February, May, August, and November to approve courses. The current list of approved courses is always on the website, but it does take a little while for the course to show up if you've taken it and show up under your CE page there. Make sure you get them in sooner than later. There's always a mad rush at the end of the year for people getting in courses and CE credit, so the sooner the better. Each and every year we talk about the Professional Recovery Network. I want to mention it here again, especially for those of you who are new to the state or if you've had a circumstance that might require the use of the Professional Recovery Network. It was established in 1981 by the Texas Pharmacy Association, and optometry was added in September of 2010. It helps professionals, students, and professional staff in the fields of pharmacy, optometry, dentistry, and veterinary medicine to overcome potential impairment issues due to substance abuse or mental illness. So before 2010, the way that it used to work is that if you found a doctor with a mental health issue or a substance use disorder, really the board only had one option, and that was to take away your license. With the Professional Recovery Network now, the reporting and treatment are confidential. The goal is providing public safety and giving the doctor or the student or whoever it might be an avenue to seek treatment without taking action against the professional license. The criteria there only apply if the individual complies with the treatment program that's laid out with them. Pretty much anybody can send you to the Professional Recovery Network. It can be yourself, it can be a third party, it can be an investigator, or it can just be an order from the board. And again, so long as you comply with the treatment program, the disciplinary action against the license will not be taken. Just for your information, there's a couple seminars that are held each year in Austin. You can find more information on the Professional Recovery Network's website, which is listed here. This is the calendar of events here for the spring seminar on May 5th. So that'll do it for me. Here's my contact information, and please reach out if you have any questions. I'm happy to answer anything that we've talked about here. I am not a legal expert or an attorney. I have just been charged with going over these rules and laws. I've read through them, and so I have a relatively good understanding, so I'm happy to answer anything that you may have questions about. The board contact is there, Chris Cloris as well. I will leave you with this thought one more time. If you are not a TOA member, please consider joining. We really need to stand together as Texas optometrists, and so I take this opportunity and this platform to ask you to join. Hopefully you enjoyed the presentation. I appreciate you sitting through it, and hopefully we'll see you next year.